Hello, I'm Tom Davis, and I'm giving this presentation along with Mirela Oprea. We're both with World Vision International. World Vision works in 100 countries through 35,000 staff members, 184,000 community health workers in 46 countries, over 300,000 faith leaders, and 112,000 other volunteers. Currently, we have 3.4 million children who are supported by individual donors, and we have a response to COVID going on, which reaches 62 million people, including 27 million children. A couple of additional World Vision numbers in terms of our reach. We offer humanitarian assistance to over 27.1 million people in response to 66 natural and human-made disasters across 48 countries. We're serving 10 million people in 31 countries with food support, 6.4 million people in 41 countries with cash or voucher-based programming. We're reaching 8.2 million people with hygiene behavior change, and 2.7 million people are being helped to gain access to improved sanitation. This model is one way that World Vision is applying behavioral science through a multi-sectoral version of the care group behavior change approach, which we call nurturing care groups. This model is used to promote the behaviors associated with most elements of the nurturing care framework, which was released by WHO and UNICEF back in 2019. And the purpose of the model is to promote basic parenting skills and adoption of key behaviors from most sectors, not just health, nutrition, and WASH, where care groups have traditionally been used, but it's also child protection and early child education, where it has been used less often, and possibly also caregiver mental health. With this model, we give the option for working with almost every household in a community, such as households with children 0 to 18 years, or a more targeted approach, such as households with pregnant women and children under 2. The early World Relief Gaza Child Survival Project, which had outstanding sustainability at 4 to 5 years after the end of all project funding, reached almost every household, and that approach also allows one to address issues that affect older age groups such as adolescent nutrition, childhood injuries, menstrual hygiene, etc. I've worked a lot with Henry Perry at Johns Hopkins School of Public Health on this model, and we both believe that if we want to scale up the nurturing care framework and the Thrive agenda for children, we need to have more and more countries using 2 tiers of community health workers. The current tier, who often work a few days a week or full-time, and eventually they should all be paid, and a second tier of volunteer community health workers who can focus mostly on behavior change with limited hours, about 8 hours a week or less. Without these 2 tiers, we don't see how we can address all of the things we need to address without severely overloading community health workers. The Nurturing Care Group project model and the care group approach on which it's built is a community-based strategy for improving coverage and behavior change. It was developed originally by Dr. Peter Ernst with World Relief in Mozambique, and it's been used subsequently in more than 30 countries by more than 30 organizations. I was one of the co-pioneers of this approach in Mozambique. World Vision has used or is using care groups or the Nurturing Care Group version of care groups in Ghana, India, Nepal, Uganda, Zimbabwe, Malawi, Sudan, and South Sudan. And the project model has been used in 30 or more countries by other international NGOs. The approach focuses on building teams of volunteer caregivers who are mostly women who are selected by their peers and represent, serve, and do behavior promotion with blocks of about 12 households each. Care group volunteers are pure volunteers. They receive no monetary incentives, just job aids, yet we usually see only about a 5 to 10% annual dropout of these volunteers using this project model. One of the reasons that we're excited about this model is that it's outperforming other models in terms of behavior change, outcomes, and cost per outcome. This 2015 study compared the effectiveness of multiple care group projects in 5 African and Asian countries to other USAID-funded child survival projects that did not use care groups in terms of coverage of key child survival interventions and the under 5 mortality rate. And this table shows the mean changes in adoption of behaviors of care groups and non-care group projects. So for example, hand washing with soap rose 20 points on average in non-care group projects, but 43 points in care group projects. In this study, 10 care groups and 9 non-care group projects were matched by country and year and program implementation for comparison, and they all had similar budgets. That evaluation found that care groups had double the behavior change of non-care group projects and had 53% greater under 5 mortality reduction. So this is not just new, but a better model. We've also done evaluation of the nurturing care group model in Ghana just recently. This was a 15-month quasi-experimental design study. It had a focus on reduction of harsh punishment of children under the safety and security element of the nurturing care framework. We spent about 3 months promoting child protection behaviors as part of that. And these results are based on differences in differences, which were generally about 10 to 35 percentage points at the P as less than 0.05 level. Caregivers reached with the nurturing care groups versus the controls were less likely to use 8 different forms of physical violence against the child, more likely to often or always praise a child in 6 specific ways. We ask about each of those 6 separately. More likely to know and practice relaxation techniques as a caregiver, more likely to inspect their house for safety issues, and less likely to say that punishment that they give depends on their mood. They were also more likely to often or always do 8 different positive things with a child, like volunteering with their activities in sports, playing games with them, asking about school and other things. In addition to that, we promoted wash behaviors using this model, and we saw similarly good results for those behaviors. The yellow lines are for the intervention group and the blue for control. And note that substantially more intervention households had lower detectable E. coli in their drinking water, soap for hand washing, and animals penned during the day. They were also more likely to properly store water, to have basic sanitation, to keep children away from animal feces, and to practice food hygiene behaviors. So what are some of the reasons that this model seems to be outperforming other behavior change models? Well, we think there are a number of reasons for that. An important one is that the nurturing care volunteer is usually selected by the caregivers and the households that they serve, which leverages Cialdini's liking persuasion principle. This is not true of most community health workers. They're often chosen by the community or by a community leader, but not by this small group that they'll continue working with. It has very high coverage as well. Most caregivers of children or young children are reached over 20 times a year for 1 to 2 hours in each session. It leverages the advantages of both group settings and home visits. So caregivers are reached in group meetings, which can help with changing social norms, but also through home visits where relationships are built, where messaging can be tailored to the individual caregiver, and where other family influencers can be reached, like husbands and mothers-in-law. The lesson plan is also standardized and built on effective behavior change principles. For example, those that leverage Cialdini's social proof, commitment and consistency, and reciprocity persuasion principles through use of techniques like testimonials, asking for verbal commitments, exploring barriers, use of change talk type questions from motivational interviewing. And the lesson plans can also be tailored to address the particular behavioral determinants found in the project area from barrier analysis studies. This model also has extensive use of volunteers, which leads to a better cost per beneficiary, which in turn leads to a better cost per life saved and the behavior adopted. We also have several excellent studies on outcomes from 4 to 5 years after the end of care group projects, which shows a high level of sustainability of both the results and activities. I've posted a couple of links here to those, and I have other studies if you'd like to see them. So I mentioned barrier analysis. This is another tool we use to boost behavior change in our programs. World Vision has used barrier analysis extensively in our WASH programs and some of our other sectors, and it's being used by more than 38 organizations in 59 countries, more than 40% of all lower and middle income countries. The purpose of barrier analysis is to identify behavioral determinants of a particular behavior so that more effective social and behavior change messages, strategies, and supporting activities can be developed. It's based largely on the health belief model and the theory of reason-action models, but it's flexible in that regard. And a key feature is that you interview those doing a behavior, the doers, or intending to do a behavior, and compare the responses to those who are not, the non-doers. Analysis is done with an Excel spreadsheet, and it was used extensively during the Ebola outbreak, and we're now using it to study acceptance of COVID-19 vaccines, comparing responses from people that plan to get a COVID-19 vaccine or have received one already with those who do not and do not plan to. These are the main determinants that are explored in these studies, things like perceived social norms and perceived susceptibility. One of the reasons that we like to use barrier analysis rather than just doing focus group discussions or cross-sectional studies on people's beliefs around behaviors is those other methods can lead one astray. For example, when we interviewed people in a rural area of Bangladesh about the perceived advantages and disadvantages of getting a COVID-19 vaccine and what would make it easier for them to do so, we found quite a few things that were mentioned by high proportions of people, such as fear of negative side effects, which you can see here, that were in no way correlated with being an intended acceptor or non-acceptor of the vaccine. None of the differences of these things shown on this slide are statistically significant. Instead, here are the things that were most highly associated with intending to get a COVID-19 vaccine in Bangladesh, and all of these are statistically significant. Social norms, for example, were very powerful. Respondents who believed that most close family and friends would get the vaccine were much more likely to say that they would get a vaccine. Respondents who said most of their community and religious leaders wanted them to get a vaccine were also much more likely to seek the vaccine, as well as those people who believed most people in general will get it. Perceived risk was also important. Non-acceptors were 6.8 times more likely to say that they were not concerned at all about getting COVID-19. Perceived access to vaccines was also very important, as you might expect. Acceptors were 4.8 times more likely to say that they expect the vaccine to be offered within 30 minutes of their home. Or for example, let's say that in a survey on use of positive parenting techniques, a cross-sectional survey finds that 81% of respondents believe that God approves of positive parenting. 76% of respondents say that they know some positive parenting techniques. 40% say their partner approves of their using positive parenting. And 22% say that having the child eat better is a positive consequence of using positive parenting. Armed with that data, some project staff may decide that focusing on perceived divine will is not all that important, since more than 3/4 of respondents already agree with that. But 1/4 don't know positive parenting techniques, so that's probably part of the problem. And 40% of partners don't approve, so there's probably work to be done there. A small portion believe that having the child eat better is a positive consequence of positive parenting, so that may be a benefit to talk about more. However, when we split it out by doers and non-doers, we find that perceived divine will is probably one of the drivers of this, along with the perceived consequence of having the child eat better. The cross-sectional data is not as helpful in that regard. Although perceived social norms, whether the person doing the behavior thinks that others important to them approve of the behavior, was relatively low, it does not seem to be driving the behavior. It's not associated with adopting the behavior any more than not believing it. So in this situation, one would not need to focus on it. In contrast, a perceived consequence of the behavior does appear to be associated with adoption of this behavior. And in this case, we would focus on increasing the proportion of people who believe that God approves of positive parenting, working through faith leaders most likely, and also to use the message that your child may eat better if you use positive parenting as a way to promote positive parenting. So as we do more of these studies, we're able to see some trends in terms of which determinants are more associated with being a vaccine acceptor, but also that the reasons for non-acceptance really depend on the country and are quite extensive, not just limited to a few pieces of misinformation. So we need to broaden out our activities and messaging on vaccines, I think, to be successful. And we are publishing these studies. I've got a screenshot of one that we have as a preprint right now and are working to get published. We're also doing research into several things that we believe affect behavior change, such as maternal depression. This slide shows the differences in adoption of health, nutrition, and wash behaviors, and one knowledge indicator, between depressed and non-depressed mothers in Uganda. Almost across the board, adoption was better for these health, nutrition, and wash behaviors and knowledge retention of danger signs during childhood illness by mothers who were not depressed. We think we need to tackle mental health as a way to boost the adoption of important behaviors. So for example, here we see that the depressed mothers were 58%, or the non-depressed mothers were 58% more likely than the depressed mothers to properly dispose of child feces. We also have seen that combining promotion of early child development with our treatment model for wasted children led to much better results, so we're exploring that a bit as well. And we're planning some research around women-centered design to improve scaling of multiple micronutrient supplements. There are a number of areas that we think we might be able to collaborate with you that we'd like to look into. One is a joint research around child marriage, adolescent gender norms, sexual and reproductive health, and life skills. Violence in and around schools, sexual violence against children, including in a humanitarian and fragile contexts. Also, we would like to do a retest of an expressive arts approach to psychosocial well-being among adolescents who have been exposed to traumatic events, and test other mental health interventions with the Common Elements treatment approach. And also testing this nurturing care group project model in more settings and covering a broader array of nurturing care themes, and possibly with some different techniques that you could help us to put into this model. Thank you very much.